Good evening, everyone. Good evening, sir.
Good evening, doctors. So let's begin with the neurology section of EDIC Part 1. So as you all know that EDIC Part 1 will have single best answers. Okay. So that means it's like an what do you call that? An MCQ with one answer. So the question format will be single best answer out of the 4 to 5 choices, and you must select the most correct answer. There will be brief history or a presenting problem. So you must look for the brief history and characteristic hints that are given in the question, which are aiming towards you to answer the answer, find the answer. Like lab findings, some ABG will be there, electrolytes will be there, liver kidney function tests, so ECG, X-ray, CT interpretation. I mean, you will get everything. The only thing is that you have to make a decision or a diagnostic approach. Sometimes you will get calculation based questions, or drug dosing, fluid balancing, ventilator settings, but usually you will get a clinical case scenario followed by testing of knowledge via a single best answer. So we will be discussing neurology today, and we'll be starting with this first question. So this basically has to be a question answer training, because you have to pick up an answer out of the many, and you should know the technique of reaching there. So we have a 38-year-old. You can turn your mics on when I ask for an answer. It will be nice to interact with you all. So a 38-year-old lady presents with slurred speech, diplopia, respiratory insufficiency of recent onset. Now, she has never had any problems. Today, she has slurred speech, diplopia, and respiratory insufficiency. Examination is unremarkable apart from a small goiter. There is no history of autonomic disturbance. There is no history of foreign travel. She has no rashes and is not systemically unwell. No history of antecedent infection is noted. Which of the following is most likely diagnosis? 1. Myasthenia gravis. 2. Botulism. 3. Lyme's disease. Or D. Charcot-Marie-Tooth disease. And E. Guillain-Barré.
Yeah.
Yes. What is the answer? Say again. A. So basically what we have here is a classical presentation of myasthenic crisis. Yeah. So this is myasthenic crisis. And why myasthenic crisis? Why not botulism? Why not botulism? Why not botulism? Yes.
Other systemic features are unremarkable. There is no paraparesis or lower limb weakness, no ascending or paralysis.
Yeah, the patients of botulism also, they are like toxic. They appear toxic, and they seem to be systemically unwell. This patient is systemically totally fine. I mean, you cannot make out. So then is Lyme's disease. Why Lyme's disease cannot be an answer in this situation? So Lyme's disease needs a history of being around bushes where deers are there. So the patient lives in UK, has no history of foreign travel. If they wanted you to pick up on Lyme's disease, they would have given you something. Then in Lyme's disease, there is a typical rash, which is followed by a long period of disease, no disease. And then comes the late neurological cardiovascular symptoms of Lyme's disease, out of which slurred speech, diplopia, respiratory insufficiency, these symptoms are usually not there. Then comes Charcot-Marie-Tooth disease. Why not Charcot-Marie-Tooth disease? It's very important that we, go through the answers and we define that the patient does not have it, so that, because my questions would be simpler. In examination, you would find it two options which are running neck to neck. There, knowing something will be very important, that you don't mark the wrong answer. So the Charcot-Marie-Tooth disease is basically
There is no distal symmetrical weakness or other systemic examinations were unremarkable. There's no sensory loss also, which is mentioned here.
Yeah, and then it is a heterogeneously genetic disease which presents heterogeneously. So the patient would have some symptoms from younger age group. She is 38, but this is an inherited disorder, we all know, and it is like demyelinating or axonal damage is there. So the patients usually present with distal muscle weakness first, and starting in feet and legs, and then progresses proximally. There's foot drop, difficulty walking, and then there is a typical shape of the legs which is called that champagne glass appearance. So the patient will have telltale signs of Charcot-Marie-Tooth. Why it cannot be Guillain-Barré syndrome?
No autonomic dysfunction, no
Very good.
GI symptoms previously.
Yeah, so she does not have any antecedent infection history. So this question has, very effectively given up all the answers, and we can have the answer now, and the answer is myasthenia gravis. So myasthenia gravis, we all know it presents usually and commonly in women in their fourth or fifth decades. Ocular symptoms being common, initial presentation known as myasthenia, ocular myasthenia. There may be other diseases like, hyperthyroidism, goiter, thyroid-related dysfunction. Autonomic disturbances, classically, they are not a feature of myasthenia gravis. But these patients may have muscarinic symptoms because of the patients can have muscarinic symptoms because of pyridostigmine, which is a acetylcholinesterase inhibitor. Yeah, so the patients may have drooling and all those things sometimes due to over parasympathetic activity. We've already discussed botulism cannot be here. It is a toxic disease. It is caused by a very toxic kind of bacteria known as Clostridium botuli. So it leads to cranial nerve signs, including diplopia and ptosis, but there is a flaccid descending paralysis, which is a classical symptom of it. And it is caused by presynaptic inhibition of acetylcholine released by neurotoxins A, B, and E, which usually have a history of eating contaminated or canned foods. Unlike myasthenia gravis, antimuscarinic features may be there, like dry mouth, mydriasis, constipation, and